Okay, good morning, everybody. Nice to see a semi-full room. So before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, and many others whose histories, languages, and cultures continue to enrich our vibrant community. This is always a pleasure because, of course, we all know and fondly remember Tom Marrie. And so in his honor, we have an annual lectureship that's sponsored by the Division of Infectious Diseases. And so without any further ado, I will ask Dr. Stephanie Smith, our Division Director for ID, to introduce our guest speaker.
Thanks, Norman, and welcome, everyone. It is my pleasure to introduce our Tom Marrie Lectureship speaker for this year, and it's Dr. Susy Hota. Dr. Hota is an associate professor in the Division of Infectious Diseases at the University of Toronto and the division head for infectious diseases at the University Health Network and Sinai Health in Toronto. She completed her medical training and Master's of Science in Clinical Epidemiology at the University of Toronto. And after joining UHN Infection Prevention and Control in 2007, she became the medical director in 2016. Her academic interests include the management of C. difficile infection, fecal microbiota transplantation, and emergency preparedness for infectious diseases. She is currently the Shea Vice Chair of the ID Week Program Committee and President-elect of the Association of Medical Microbiology and Infectious Diseases Canada. She is also the co-chair of several working groups within the Canadian Nosocomial Infection Surveillance Program. And she has played pivotal roles in the regional response to COVID-19 within Ontario, and has frequently been featured on national media as an expert in health systems response to emerging infectious diseases. Please help me in welcoming Dr. Susy Hota.
Hey, thank you very much for that kind introduction. And I really am honored to be here today to be giving this talk for you. So I'll be talking about C. difficile infection, our old foe, who continues to reinvent itself so that it can be a viable topic for medical grand rounds and other such reasons. But I did want to start by acknowledging some relevant disclosures. So I have provided consulting services and participated in advisory board meetings for Ferring Canada. This is a company that manufactures a fecal microbiota product that's used for treatment of recurrent C. difficile infection. As Dr. Smith had mentioned, I am president-elect for AMI Canada, and I participated in the development of C. difficile treatment guidelines in 2018. I won't be referring to those today, however, and I am co-chair of the Canadian Nosocomial Infection Surveillance Program C. difficile Working Group, and I will be actually showing you quite a bit of data from what we fondly called CNIS Peer as I go through the epidemiology of C. difficile and what's happened over the last 2 decades. Okay, so my objectives today really are to review how C. difficile has changed epidemiologically. This is telling you about trends in infections over time, but also how the different strains have evolved. You know, to actually refer to my topic and my title, I will be talking a little bit about the molecular epidemiology of C. difficile, but not just the molecular epidemiology, but also how strains to the healthcare system have impacted on not just the incidence, but also the outcomes related to C. difficile in Canada. Then I'll be just quickly going through some of the ongoing diagnostic challenges that we have with C. difficile infection and highlighting some of the most relevant medical management updates with C. difficile. So here's what we're going to be talking about as a quick reminder for those of you who are less familiar with this pathogen. Clostridioides difficile is a gram-positive spore-forming anaerobic bacterium that is actually quite common. About 5 to 10% of healthy adults carry it within their colon as part of their flora. However, under certain conditions, it can be triggered to cause a toxin-mediated disease that usually shows itself as profuse watery diarrhea, but it can actually progress to something much more severe in a select number of individuals, such that 3% of people can have quite a fulminant course that can result in the need for a colectomy or death. Now, I would argue that C. difficile remains a priority pathogen internationally. And this is actually in contrast with the updated list of bacterial priority pathogens that the WHO released last year, in which C. difficile was no longer on that list. And that's actually sparked quite a bit of debate and commentary, such as what I've highlighted here in Lancet Microbe from international experts who point out that this remains a real problem for most parts of the world. Here in Canada, where we're about 40 million people, C. difficile is estimated to cause at least 38,000 infections per year and result in about 281 million Canadian dollars in cost to our system and to individuals on an annual basis. And for those who are hospitalized with this, it can increase the length of stay by an average of 3.6 days. So it does have quite a bit of impact. And on the patient side, morbidity and mortality associated with it remain an issue. And the main form of morbidity with C. difficile infection is the fact that about 20% of people get stuck in cycles of recurrent disease in which they're continuing to have episodes of C. difficile infection that impact their life in many different dimensions. Now, C. difficile infection really came to our attention in the early sort of turn of the millennium, so early 2000s. And the reason being that there was an emergence of a particular strain of C. difficile that we were referring to as the NAP1 strain, based upon pulse field gel electrophoresis pattern. It stood for North American Pulse Field Type 1. And this particular strain of C. difficile really spread quite rapidly across the eastern seaboard into Quebec and Ontario and throughout Canada, and became a dominant strain. And it became very apparent that it actually resulted in additional clinical morbidity and mortality. And some of these graphs here from a study that was done through the Canadian Nosocomial Infection Surveillance Group in 2005 demonstrate that change or that difference in mortality between those who are infected with a NAP1 strain versus those who are not, which is what you see in the graph in the upper panel, as well as the effect of age on that. So as you got older, that impact actually became even more pronounced. And severe C. difficile as well, so outcomes related to severe C. difficile infection. Now, that NAP1 strain, which we refer to sometimes as a hypervirulent strain of C. difficile, actually remained a dominant strain for a good decade or so. And so it peaked in its prevalence back in 2008, where it was about 50% of the different C. difficile isolates that we were doing surveillance on in Canada. And we really began this more concerted effort in doing surveillance on C. difficile in 2007 related to these issues. After that, it slowly started to decline. You can see that at the top of this graph, but it still remained the dominant strain, at least up until the early sort of 2010s. And it was resulting in a lot of these large facility-wide outbreaks of C. difficile that really got my attention, and the reason why I got interested in C. difficile as a pathogen in the early stages of my career. Now, following that stage, a lot of investment was made into infection prevention and control departments, into antimicrobial stewardship, which was just kind of an emerging specialty or subspecialty within infectious diseases at the time, and cleaning and disinfection of hospital environments, et cetera. And we saw the gains that came from that. So in what we consider the post-epidemic period between 2009 and 2015, again, CNIS published this really nice paper in CMAJ, which showed how the national rates of C. difficile healthcare-associated infections, at least, were coming down beautifully. And so overall, in that period, they reduced down by about 27%. And from its peak in 2009, down by 36%. So dramatic decrease in what we were seeing in rates of C. difficile infection in hospitals. And interestingly, we were seeing some different shifts as well in the molecular epidemiology that coincided with those changes. So at the very top of this table that was in that same publication, you can see over time how the NAP1 strain significantly decreased, as well as a NAP2 strain, while there was compensatory increase in NAP4, NAP6, as well as NAP11 strains. So we're seeing some shifts in what was actually circulating that may have been driving some of those clinical changes and the risk change that we were detecting. And in fact, an analysis was done in this paper that showed that NAP1 versus non-NAP1 strains had a 1.9 times higher risk of death. So the outcomes were different within this cohort of individuals. And they calculated that for every 10% rise in the proportion of NAP1 strains that you were seeing in your facility, it would result in a 3.3% increase in your C. difficile infection risk. So the rates that we were seeing. So that was an interesting observation. It was really one of the first times that I've seen in C. difficile where this relationship between what was circulating molecularly was actually really tied quite beautifully to what we were seeing epidemiologically and on the clinical side. And the surveillance continues. So we continue to do surveillance on what's happening in terms of rates of C. difficile, but also some of the clinical outcomes, et cetera. And you can see beautifully in this interrupted time series that CNIS also published in 2022, the rates of C. difficile continue to come down beautifully up until about 2019, 2020, when boom, the world faced another great strain, of course, the COVID-19 pandemic. And during that time, we changed the way that we lived. And that resulted in a significant increase in not only healthcare-associated C. difficile infections, but in the second panel of this graph, you see quite pronounced increases in community-associated cases that were then coming in and being detected in hospital. That's how our surveillance works. And so this significant increase in both of these forms of C. difficile was seen for sort of the early pandemic period, 2020, 2021. We asked the question, does COVID-19 play a direct role in this change that we're seeing? And it was a really difficult one to answer given the type of surveillance information data that we had. But we did see that in 2021, when we looked at those individuals who had C. difficile infection in our surveillance program, 5% were co-infected with SARS-CoV-2. And an observation that we were able to make is that patients who were diagnosed with COVID-19 and in the hospital were more likely to actually develop healthcare-associated C. difficile infection compared to those who did not have COVID-19 infection and were in the hospital system. So there may have been some, other biologic reasons why this was happening, but we did postulate that a lot of this may have been driven by things like avoidance of healthcare contact during the early stages of the pandemic and people, temporizing management of things that could or could not be infections with a slight increase in use in antimicrobials, for example, changes in infection control practices within hospitals because of all the pressures that we were facing with COVID-19. So there are a variety of reasons that we can't prove that we postulate were involved here. So as I mentioned, we continue the surveillance of C. difficile because it is still one of our priority pathogens, at least here in Canada. And so this is some data that we recently published in Emerging Infectious Diseases. We realized that we had some depth to our data in that we collect data not just on adults, but we've expanded our network and we additionally have more and more mixed hospitals where pediatric care is also offered and some standalone pediatric sites. So we thought, let's look at what's happening between adults and peds. There's not a lot out there with children and C. difficile risk. This is a graph that we published that shows you what's happening in the different regions. And because of our the way that we're organized, we really separate into the Western, Central, and Eastern regions. So the Western region is sort of anything Manitoba and West. Central really is Ontario, Quebec, and then the Eastern region captures the rest of the provinces. And we more recently added some Northern representation, but that was just very recent and we don't have a lot of representation yet. That is one of our goals. So what you see here is that across the adult populations, healthcare-associated C. difficile infection decreased by about 20% between 2018 and 2022. In pediatrics, about 30% of a decrease overall, although you do see those blips related to the early stages of the pandemic that I mentioned. Whereas with the community-associated C. difficile infection, we really didn't see a change with adults. It remains, at the same sort of stable level of ongoing prevalence. With children, however, we saw quite a dramatic decrease, about 58% decrease. Additionally to this, we noticed that there's some trends in the clinical outcomes of our patients. So recurrence of C. difficile infection, which I had mentioned earlier on, happens in about 15 to 20% of people. If you look at the overall literature of C. difficile internationally, we found that our recurrent risk in 2022 is around 8%. So it's actually decreased. And similarly in children, it's about 7%. So that's interesting. And that might have to do with our decreasing rates overall, but also changes in how we're managing patients and the strains that are circulating epidemiologically. And also CDI-related or attributable mortality, which is a bit challenging to estimate, but we've used consistent methods of doing so in our surveillance over time, also seems to have decreased. So we're now seeing attributable risk of death being, attributable mortality being between 1% and 3% in patients with C. difficile, which is actually quite a bit lower than what we were seeing earlier. Now, I mentioned some of this might be because of the differing strains that are circulating. So what's happened over this time? Has it continued to shift in the directions that I showed you in that last publication? And the bottom line is yes. So this orange colored line on the top graph shows you, the NAP1 strain, what was previously referred to as a NAP1 strain. We've now changed the way that we do the molecular characterization of C. difficile strains. So we do ribotyping, and so that corresponds with the RT027, the type 27 ribotype on ribotyping, and that's decreased significantly over time. And we've seen increases in this RT106, which corresponds with the NAP4 and NAP11 that we also had seen increasing in the last study. So definitely some shifts even in these top 5 strains of C. difficile that are circulating. And again, on deeper analysis, we could show that this NAP1 strain, once again, was at more of a risk for severe disease with C. difficile compared to the non-ribotype 027 types, and also more likely to cause healthcare-associated C. difficile in adults. So lots of interesting trends that we're monitoring and associations clinically that are likely connected to these different types of strains. So that's what I was going to really just cover epidemiologically in terms of what's happening with C. difficile and how some of the strains that we face to the system and that we'll continue to face to the system can impact on what's circulating, but also how patients are actually, seeing how often they're seeing this infection and what their outcomes are like. I'm going to shift a little bit now to some of the diagnostic challenges that we continue to face with C. difficile infection. Now, this seems like a very straightforward problem, right? People get diarrhea, you test them, they're positive, you treat them, you're done. It turns out that there's a lot more nuance to it, and especially when you're dealing with recurrences of disease, which I said is the greatest driver of morbidity in patients with C. difficile infection. So most of what I'm talking about is going to be focusing on how this is relevant to recurrent C. difficile infection. All right, so just to kind of drive home what I'd mentioned, this is something that traditionally we expect happens in about 15 to 20% of people. I just shared with you that maybe our recurrence rates are coming down a little bit in Canada, but internationally, this is really what we expect. The main risk factors for recurrent disease are actually very similar to the risk factors that you see for getting C. difficile in the first place. So age, and that might have to do with changes in the intestinal microbiota over time, but also the way the immune system can function differently over time. Antibiotic exposures, again, related to the concept of dysbiosis, which is changes in the resiliency and the composition of your gut microbiota because of exposures like to antibiotics. Hospitalization, you know what we do in hospitals, we cram a lot of people into shared spaces and make them share bathrooms, and that can result in transmission of conditions like C. difficile, especially given that most of the transmission occurs through spores that can be left behind in the environment and can last for months and months, even in the presence of our usual cleaning protocols. And then gastrointestinal surgery or disease can put people at risk. Similarly, if people have underlying inflammatory bowel disease, they may be at greater risk. Immune suppression, chemotherapy on its own, because it also will take away some of your defenses by destroying the lining of the bowel, puts you at risk, but it also suppresses the immune system. And proton pump inhibitors tend to be on this list, although they're a little bit less of a potent risk factor compared to the others that I've mentioned. But truly the most important risk for recurrent C. difficile is recurrence itself. So once you've had one recurrence, you're at greater risk for it to continue coming back. And I think that speaks to, again, this concept of your gut flora has been altered in such a way that you can't fight off this condition. You can't eliminate the spores. Quite often people will continue to be colonized with C. difficile long-term, but also you just cannot keep it in check. And the reason why people end up in this problem is twofold. So I mentioned colonization or carrying C. difficile long-term. This is actually what occurs in the majority of people who've had a single episode of C. difficile infection. But in general, 8 to 10% of patients who present to our hospital from the community will actually carry C. difficile if you tested them for it and you're looking for the presence of the organism in their gut. This increases as people are hospitalized because of some of the factors I mentioned, such that studies have shown up to 20% of hospitalized patients may be colonized with C. difficile. And then in long-term care, it can be even more complicated because we don't manage things in the same way with infection control measures. And people live there, that's their homes. And there have been some studies that during outbreaks have shown up to 50% of residents of outbreak units become colonized in that setting. But on top of it, it requires this condition of dysbiosis that I mentioned. And this is a nice graphic, I think, to show you what the difference is between a healthy gut, in which there is quite diverse microbiota within there. So, types of microbes in there, and they interact with your immune system. And there's just a nice ecosystem in place that keeps you healthy and can actually resist potential pathogens or opportunistic pathogens like C. difficile. But when the gut microbiota becomes altered by either exposures or, changes that happen naturally over time, you lose that resiliency and that ability to, as we call it, undergo colonization resistance with some of these types of opportunistic pathogens. All right, so you're worried that a patient may have C. difficile infection. Let's talk about how we begin diagnosing them. Well, the clinical signs and symptoms are usually quite, non-specific, and there's nothing that's pathognomonic for it, to C. difficile. The hallmark of symptoms is watery diarrhea, and it's less than 5% of people that end up with bloody diarrhea. So that's a minority of cases. It's almost always just watery diarrhea. We use tools like this, the Bristol stool chart, increasingly to try and characterize people's bowel movements. But something that you learn over time is that what's normal for one person is highly dependent on that individual. So people's interpretation of what is diarrhea or what is abnormal in their bowel habits can be quite varied. And so trying to be systematic about it is probably your best bet, and following people over time as compared to their baseline. But the diarrhea is a big component. There may or may not be abdominal pain. There may or may not be fever. There may or may not be nausea, vomiting, and sort of more upper GI type symptoms along with it. And there quite often is a suppression of appetite and just general, malaise and feeling quite weakened by it. When you do labs, again, very non-specific findings can come up. You might have hypokalemia. You may have, an associated acute kidney injury. But there's really, you may have a reduction in albumin. There really isn't a lot that will help you to determine if this is due to C. difficile or something else. You may go on to do imaging, in which you may or may not detect signs of colitis on a CT scan. Abdominal X-rays really aren't that helpful in this setting unless you're concerned someone may be progressing to a toxic megacolon. And if you're so lucky as to have endoscopy, you may or may not see these typical pseudomembranes. This ends up in a minority of cases, so it's usually not that you're seeing. You may see some chronic active colitis. Biopsies may be suggestive of the same. But this is what the pseudomembranes would look like if you were to actually see them. So really, on that sort of clinical side, the identification largely lies with the symptoms and following a patient over time and interpreting those symptoms as to whether or not that's normal or abnormal for them. And again, in the incident case of C. difficile, it's not so difficult because people notice some sort of a change and they report that, and then you go ahead with testing and you sort of come down this avenue. But it's really in those recurrent disease episodes that it can be really quite tricky. And comparing to their baseline is critical. Thinking about other things like bowel routines that could be contributing to it, initiation of new medications, etc. And then you get to the testing. So testing is really just one small component of all of this. And part of that's because we have a lot of limitations in what you learn from the testing. So specific tests for C. difficile can fall into different categories. There are those that target the presence of the toxins themselves that actually are involved in the inflammation of the bowel that causes symptomatic disease. So included within here are cytotoxicity assays, which we really don't use. These are reference methods. They're not very practical and they take a very long time to come back and cannot be performed in many labs. Enzymatic immunoassays, so EIAs, have been used over time quite frequently. Membrane assays also can fall into here. And then there are those that target the actual organism itself or some component of the C. difficile organism itself, such as culture, anaerobic culture. Again, very challenging to do, only done in some reference labs because it requires an anaerobic chamber. It's very difficult to recover this organism and actually grow it. Not practical, but it is one of our reference tests or gold standards. Glutamate dehydrogenase, again, an EIA this is present on all C. difficile, but it will not be able to tell you the difference between toxigenic and non-toxigenic strains of C. difficile. And then there are those that target whether you have toxigenic C. difficile present through a variety of methods. So there's cytotoxigenic culture, again, a reference type test, but not easily accessible to people. But very, very frequently now, people have moved to these nucleic acid amplification tests, PCR, et cetera, because the benefits here are they are good tests in terms of getting you an answer. They target the genes that encode these toxins, so you know that they're toxigenic C. difficile that would be present. And most importantly, they have a very rapid turnaround time. And that became really important in the earlier days of C. difficile, where some of the transmission at least could be attributed to not having early enough detection of cases that would prompt infection control, isolation, et cetera, in the hospital environment. So how do these all stack up? I've pared it down to the 3 most common tests that we still see in use, although there are a variety of other ones that you see in different public health labs, et cetera. But that glutamate dehydrogenase test is a pretty sensitive test, so it's good as a screening test. However, it lacks the specificity because it doesn't distinguish between the toxigenic and the non-toxigenic forms of C. difficile. Then the toxin EIA tests actually are quite easy to do. They're readily available. They're cheap. However, they lack sensitivity depending on which one you're using. The newer generation ones are better, so that's good. But overall, there are some sensitivity issues. They are, however, quite specific. They do tell you that you've got toxin present causing the problems that you're seeing with your patient. And then those nucleic acid amplification tests, as I said, in sort of the late 2000s, early 2010s, really took off as being the standard for a lot of labs because they're quick, easy, and the turnaround time is quite good, and they're very highly sensitive and specific. The problem is they're detecting the presence of a gene, and they don't tell you if those toxins are actually being expressed in every individual. So there is that shortcoming that may make you overcall the diagnosis. And overcalling C. difficile is a real problem in terms of the methods that you're using. This is, I know, a very busy slide. I apologize, but it's an excellent study that was done published in 2015 and got a lot of attention that really highlighted this issue of overdiagnosis of C. difficile. It was a prospective single center study. It involved, in the end, 1,416 patients. And what they did is they tested all these patients who presented with diarrhea or symptoms that the clinicians believed could be C. difficile. Concurrently with the toxin EIA testing and PCR, and they also sent them for culture. But they only released to the clinicians what the toxin result was. Okay, so if it was toxin positive, they find out and they'd be, given that they suspect this patient had C. difficile infection. If it was negative, they would have to interpret this as a toxin negative test result. Then they followed all these patients out, and they were interested in seeing what happened in terms of duration of diarrhea in these patients up to 14 days out, and whether there were any complications that arose from the infection, the C. difficile infection. So about 55% of their cases, of their PCR positive cases, ended up being toxin negative. So they did not actually demonstrate the presence of the toxin itself. And interestingly, what they found was the median duration of diarrhea in the group of patients who were toxin negative and PCR positive was quite similar to those that were toxin negative and PCR negative. So what you would call completely negative and not in testing, compared to if you were toxin negative, but the PCR was positive. And it differed from what they saw with the toxin positive, PCR positive group. And there were no complications in any of the individuals who were in that toxin negative, but PCR positive group. And they did see 10 complications in those who were positive on both of the tests. So there was a significant difference here, and they were able to interpret this as there was no harm in withholding that information about the PCR test and basing their results or their call on the toxin test. Now, that got a lot of attention. It hasn't shifted a lot of labs, like all labs, towards this because there are other logistical reasons. And I will say there are many nuances. These are mostly people with their first episodes of C. difficile, where, again, it's quite clear that their symptoms have deviated from their norm. Whether you were to apply this to patients with recurrent C. difficile, where it gets a bit complicated, and see the same sorts of results is not really known. So I would say you can't take this as being the answer, that we should all just switch to just toxin tests alone. I think there are many more nuances. But what it's led to is this growing concept in guidelines in Europe and especially and across the board of thinking about having multiple tests to actually help to delineate what's going on with a patient. This is one example from the Public Health Ontario lab, but you have a different, algorithm here, and we see many of them across the board, where you start with a much more sensitive test. So in this case, it would be the GDH test that I mentioned. And if that is positive or invalid, you would you follow up with a second test that's more specific, a toxin-based test. If it's negative, you could feel fairly confident that you're not dealing with C. difficile infection and report it out. And there are different ways that this has been designed and different tests that have been used in these two-step algorithms and other multi-step procedures. Now, there are many publications out there that show you that, yeah, this actually results in a reduction in your C. diff rates. Yay. And you do have to think about this actually in interpreting that first half of what I talked about in terms of rates, that our testing methodologies have changed over time across sites, and we don't have great information that we could factor in. This comes up every time we talk about our C. difficile epidemiology and surveillance. We can't really add that into our analysis yet, but it's something to think about. And this is a nice study that was published just last year that showed that when they initiated at the center what they call a reverse two-step algorithm for C. difficile diagnostics in their micro lab, they saw a beautiful decrease at the top panel of their hospital onset C. difficile rates. Interestingly, when they looked at what was happening with antimicrobial utilization, however, it didn't follow that same dramatic decrease. So what that tells you is clinicians will do what clinicians will do, right? They will interpret the test results however they feel makes the most sense, and that's valid. So you don't necessarily realize some of those stewardship impacts as easily when you make these changes in the lab. So my bottom line is, when we're talking about C. difficile, especially recurrent C. difficile, the most important thing you can do is follow their symptoms. Develop the relationship with the patient, understand what they've been through, and interpret it according to their symptoms. The test results are less useful usually. And why that's particularly important with recurrent C. difficile, these nuances I've alluded to, is this concept of irritable bowel syndrome and post-infectious irritable bowel syndrome that we see fairly frequently with patients with recurrent C. difficile infection. There are two nice studies I wanted to highlight here just very briefly. One is a single-centered cohort study where they had 684 patients who had been diagnosed with C. difficile infection. They had a history of it. And they followed these patients up with these questionnaires, what is used to help diagnose irritable bowel syndrome, the Rome-3 criteria. And then they also collected some detailed symptom history and medical history on these patients. They got actually a pretty good response rate. 315 patients did respond. They'd identified that 205 of them were considered at risk for having irritable bowel syndrome. And 25% of these individuals met Rome-3 criteria for IBS more than 6 months after having recovered from their C. difficile infection. So this is a good way to characterize what we're dealing with after you've had inflammation of the gut for any reason. It could be traveler's diarrhea, it could be anything, but in this case, C. difficile. There are often lingering symptoms that occur in this fashion, and about a quarter of them would meet these criteria for IBS. Another study that I thought was really neat is a single-centered observational study where they characterized patients that were referred to their C. difficile clinic. So they had a dedicated C. diff clinic. The majority of these patients, or 211 in the study, 199 of them were referred for the purpose of being evaluated for recurrent C. difficile infection. So that's what their referrals said. And when they actually evaluated these patients, the diagnosis of recurrent C. difficile was only really there at the end of the day in about 60% of their patients. And the majority of those that had non-C. difficile related diagnoses were diagnosed with post-infectious irritable bowel syndrome. So it is something you have to keep in mind and in evaluating your patients in a condition where the symptoms really are the most important way that we can gauge what's happening with them. All right, I'm going to move to sort of the final part of my talk, which is about the management of C. difficile. There's lots you can talk about in terms of management of C. difficile, but I'm really going to just highlight a few select areas that I thought were important to share. And one's around fidaxomicin. Remember that drug? It was supposed to be not a miracle drug, but it was going to change the landscape to some degree. And then I'm going to talk a little bit about microbiome-based therapeutics, which is an interest of mine. So our treatment guidelines for C. difficile really still date back to these 2017 guidelines that were released by the Infectious Diseases Society of America. So they're quite a bit, they're getting a little bit older now. Again, I said in the beginning of the talk that AMI Canada also released guidelines around the same time. There are a lot of similarities. I won't be focusing on the AMI guidelines, a few small differences, but I will be talking about the IDSA treatment guidelines and how they changed over time. So for the initial episode of C. difficile infection, what shifted from older guidelines prior to this that had metronidazole as the main sort of first line treatment was the presence of vancomycin and fidaxomicin as your top first line agents for treating your initial episode of C. difficile infection in about a 10 to 14 day regimen standard course. We're all very accustomed to that, but what's shifted since then is the IDSA released a focused update in 2021 in which they actually recommended fidaxomicin over vancomycin as your first line treatment for an initial episode of C. difficile infection. Now, this got a lot of chatter going. What was this based upon? It was really 4 randomized control trials that had come out at that stage, where fidaxomicin was compared to oral vancomycin standard treatment in inpatients and outpatients with first episode or first recurrence of C. difficile. These studies all exclude people with really severe complicated disease, so the fulminant disease, fidaxomicin is not very well studied in. And the pooled analyses of these studies showed that there was an improved sustained clinical response to C. difficile infection in the fidaxomicin group compared with vancomycin. So a slight increase in that sort of more durable response in patients who were treated with fidaxomicin. There was really no difference in the initial cure rate for C. difficile, no difference in mortality, no difference in safety profile, so that's good. And they made this claim with moderate certainty. This recommendation was with moderate certainty, recognizing one study was unblinded. There were a lot of self-reported outcomes. So, when you interpret this, you have to wonder, is it really worth it? Because the bottom point that I have here about the cost and the accessibility and the insurance factors are a big deal. There's a major difference in the pricing of fidaxomicin compared to vancomycin across the board. And so I do question whether this is really truly what we should be doing, fidaxomicin for first line for all patients. It may be worthwhile in some. And in fact, just earlier this year in the summer, the Canada's Drug Agency, CDA, which used to be called CADIF, if you're familiar with that older terminology, did undertake a non-sponsored review of fidaxomicin. And what they ended up recommending after reviewing all the literature independently, et cetera, and having input from various sources, was that they would recommend reimbursement for treatment of C. difficile infection in adult patients who have an initial episode of first recurrence and who are at high risk for recurrence or had an allergic reaction to vancomycin, provided certain conditions were met. So it's a very kind of conditional recommendation for reimbursement. And the way this works is this goes out to the provinces, and the provinces will decide what they want to do in terms of the reimbursement. And those conditions, fidaxomicin should be covered for these, again, initial episode, first recurrence of C. difficile, based on these sort of high risk factors, and they outline a few of them. And a lot of this came down to the economic evaluation of the drug and whether or not this actually presents good value for Canadians and for our healthcare system. And a price reduction would be recommended as well. So I'm not sure this is going to get taken up very much. I know there has been the shift in Quebec already towards fidaxomicin being an option for patients with first episode, first recurrence, again, at high risk, but elsewhere, I'm not sure where this will land. So moving on to some other relevant updates. So in 2017, again, when we talked about first recurrence and subsequent recurrences of C. difficile infection, the big shift at that time was the introduction of a vancomycin taper pulse. And it's outlined here how a standard taper pulse could be done in the first recurrence, which is moving it up from previous older guidelines where it was something we really just did when people had multiply recurrent disease. The other thing that came up here is that fecal microbiota transplantation or a microbiome-based therapeutic landed on the actual treatment guidelines for those with 2 or more recurrences of C. difficile infection. Now, that top one about the taper pulse, it's interesting. I'd be curious to hear how often that's being done here for first recurrence of C. difficile infection. It's had variable uptake, I think, in the field. And interestingly, this is an oral abstract that was presented at ID Week just last month that I thought was really interesting. It was a randomized, double-blinded, controlled study where they compared patients. So it was about 300 patients who had first or second recurrence of C. difficile, and they'd be randomized to either receive a standard 10-day course of oral vancomycin, a vancomycin taper pulse. It was slightly different from the IDSA recommended taper pulse regimen, but still similar enough, and a 10-day fidaxomicin course. And they follow these patients forward to see what their sustained clinical response would be and a number of other secondary outcomes. And interestingly, they didn't find a significant difference in the response, sustained clinical response of patients who received this vancomycin taper pulse, fidaxomicin or vancomycin. And even as they followed them further out to day 59, there's a slight numerical difference. You can see the taper pulse may be slightly better, but it wasn't statistically significant with the numbers they'd recruited. And what I thought was really interesting is that fidaxomicin actually doesn't really come out as being that much better than the other courses. So it begs the question, like, can we get away with treating some of these even first recurrences, again, with the 10-day course of vancomycin, which may be a little bit less disruptive to the gut microbiota than a longer course? So I think we still need to learn, how well these taper pulses work, what we should be doing, and what's the right balance of trying to achieve sustained clinical response, but also not adversely affect the gut microbiota as much. And that's really where I wanted to end off is, when it comes to treatment of C. difficile, I've talked about sort of standard medical management for the most part, but it is a burgeoning field and there are many different aspects to C. difficile infection that can be targeted for therapeutics. And this is a nice graphic that I came across that outlines the concepts behind them. So there's direct killing of the organism, like the antibiotics that we use, which are effective in eliminating the vegetative form of C. difficile, but we know are not active against the spores that you will continue to carry. There are phages, which I cannot pretend to be an expert in phage, but it's a really interesting area that's also developing. There are those that actually try to modulate the microbiota to help people to overcome the C. difficile infection risk. There are those that try to neutralize or target the toxins themselves using small molecule agents, antibodies, other types of substances. There's immune modulation because your immune system, I didn't mention this very much, but it is an important arm in the control of C. difficile as well. So many different agents that are being studied right now. Dozens are in preclinical stages, more in the lab, in vitro, et cetera. Fewer have made it forward to more clinical studies. But the area that I'm really interested in is what we categorize as these microbiome-based therapeutics broadly. And it can include what we're more familiar with, which is that gross concept of stool transplants. Fecal microbiota transplantation is taking stool from a healthy screen donor, administering to someone with a dysbiotic state, but also things like manipulating diet, probiotics, which are a little bit disappointing in this recurrent C. diff field because they don't seem to have a lasting effect. And quite frankly, we don't know what we should be doing to try to introduce into the tract. And the thought is it's more the communities of microbes and what they may produce that is important for protecting the intestinal microbiome. And then there are other things like microbial consortia that are being developed, engineered products that can work symbiotically within the gut, and other microbiota-derived proteins and metabolites to target the toxins, et cetera. So it's a really neat field that's expanding quite dramatically. This is already 3 years old, 3+ years old now, but it's still a great table. And I kind of like the fact that it's a bit outdated because I can update you on what's happening with some of these products. But these are some of the different products that have actually made it to clinical trials with humans, or now at this stage have become approved for use in humans. So the first one, RBX 2660, is now known as Rebiota. This has actually received Health Canada approval for use and is being used in Canadians at a very small scale as in part of the early experience program at the moment. It is unfortunately the only one on this list that has come to Canada and is approved for use in Canadians. The second one that you see here, the Finch Therapeutic CP101, unfortunately is not moving forward. It did complete its phase 3 trial, PRISM 3, but it is not moving forward into development. The series product, SIR 109, actually had promising, looking results in the clinical trials and actually has gotten FDA approval, is available for use in the US as VOWST. Unfortunately, they have no plans to come to Canada. And then a variety of these other ones here. New Biota is actually a product that originated here in Canada as kind of a neat concept, but unfortunately, last I heard, is not moving forward. And then Vedanta is a product that is currently in some phase 3 studies under the restorative trial and hopefully will move forward. I've got some hope with that one. But it's I put this up here because it introduces this other factor of how now that we've moved into sort of more commercial entities taking over developing some of these products as they should, because we as clinicians are not in a space where we can do that ourselves. It helps to move some things forward, but sometimes the market analysis gets in the way of things moving forward. So that's an interesting concept. So I've been thinking a lot more about these microbiome-based therapeutics for C. difficile that are coming out, these commercial entities, and are they helpful to us? Are they not? Well, the pros are they actually can make these products more accessible to patients, because most of us who have physician-driven FMT programs, we're contracting in size, and it's very challenging maintaining those and keeping those going. It also removes some of the risk and responsibility for me as a clinician to run a stool bank and have to do that whole operation so I can provide patients with FMTs at the end of the day. Now there's a company that takes care of it and owns some of that risk as well. But the cons are they're not necessarily eliminating infectious risks that can be transmitted through these products into patients. Depending on what the product is. A lot of these are still donor-derived products. Some of them are not so much, and that is promising, and I'm happy to see that. But really importantly, there can be less oversight. So as we get into a world where any clinician can make a decision about prescribing one of these therapeutics to their patients, what will happen? Will this be overused, misused? Can it actually introduce harms? Because these are not completely risk-free products or procedures associated with delivery of the products. And some challenges around informed consent. When you're trying to do consent for FMT, I go through quite a bit of detail of what we do in our program to mitigate risk to them. When I'm dealing with a commercial entity that's provided a product to me, some of that information may be available, but I can imagine that the average person will not have all that information necessarily. So that is a really good question. And then who's responsible as we get this out? Who's going to be monitoring what effects this has on people in the population? There are a lot of unanswered questions still. And that also got me interested in this concept of microbiome stewardship that I'd like to leave you with to think about. We talk about antimicrobial stewardship. Who's looking out for the microbes? Who's actually making sure that we're not shifting things in a way such that we're restricting the overall diversity of what's on and in humans in a negative way, especially since we don't fully understand the impact of the human microbiome and human health and disease. So I'll end off there. In summary, I've talked about the C. difficile infection incidence and the mortality and how it's declined actually. So that's a positive thing over the last 1.5 decades. Although we did see a blip in the pandemic, and we should be mindful of other health systems, emergencies, and how that can impact on these healthcare associated infections. Now, some of that's driven by what's actually happening with the strains that are circulating as well. That's not so much in our control. That diagnostics for C. difficile remain limited and actually, not so helpful, to be honest, in clinically diagnosing, especially recurrent C. difficile infection. And that with the limitations of antimicrobial therapies for C. difficile, and I didn't really mention this, but really not a desire of a lot of pharmaceutical companies to get into this space. Increasingly, we're seeing some other types of therapies come up, like microbiome-based therapies and others that I haven't mentioned that we should keep our eye on. And I'll stop there and take questions. Maybe starting with questions in the room, seeing if there's anyone who has.
Yes, that was a fantastic overview and really helpful in terms of, the current state. Because of course, those of us who do inpatient medicine see this still not uncommonly. I wondered if you could posit sort of what has been responsible for the reduction. I mean, just anecdotally speaking, there definitely was a peak in terms of virulent C. diff during, the early 2018s or whatever it was, and then during the pandemic. And it seems to have settled down despite our hallway medicine and all the things that we're doing. So what would you posit has been responsible for the SNAP1 or RTO test 27, whatever, reduction. Have we done something to help with that? Can we do something to
Yeah.
continue that trend?
It's really interesting. I think what happened is, NAP1 took over at a time prior to, obviously it was a good decade before the pandemic, decade and a bit before the pandemic when it peaked. There was this big injection into hospitals and into infection control programs and stewardship programs. So I think we strengthened the way that we actually manage C. difficile in healthcare settings. In addition to that, we improved our diagnostics. We started moving to more sensitive tests. So in 2007, when I started in infection control, we were still using a toxin EIA assay to diagnose C. difficile that probably had a sensitivity of 50% in the end. And so you'd send multiple tests and you'd have a patient sitting there with C. diff without it being diagnosed for a long time. We would isolate and be, very vigilant with that, but not every organization did that. So I think that cannot be underestimated, the impact of actually investing in these programs to increase the awareness and how we diagnose it, earlier detection, better treatments that would resolve episodes quicker, things like that. Now, with the pandemic, it's a whole other series of issues. So the strain is no longer the main driver. We got, that just came down because that was what was causing most of the C. difficile early on. When we controlled rates, we decreased NAP1. Other strains came up to take that space. But what happened in our system was we were using extended use PPE, as you recall, right? Going into one room after another. We were doing things we had to do in a situation that was really appropriate for the pandemic. And patients were not coming into the hospital. They were afraid to come into the hospital. They were having virtual visits with their GPs who couldn't assess them properly and may have erred on the side of caution and prescribed antibiotics more than necessary. So there are so many different things that we did that we can't easily measure that I believe are responsible for that increase. And not just in C. difficile, but we saw this in many other healthcare associated infections. So things happening in the hospital, things happening outside the hospital. And we should be aware of that for the next time is we had to divert some of our resources in terms of screening in the labs for healthcare associated infections, antibiotic resistance during the pandemic so that we could open up personnel and space to do COVID diagnostics. So we even lost track of some of it at that time. And now I would say next time we face something like that, we need to rethink diverting all those resources because you pay for it for years after. Yeah.
I'm just wondering about what is the downside of putting everyone on oral vancomycin? How disruptive is that to the E. coli microbiome? It's something I've never understood is like classical teaching says, oh, vancomycin, it's a gram-positive antibiotic. Oh, but there's this C. diff thing as well. I mean, is it really disruptive to the microbiome?
It is. Every antibiotic is. So IV vancomycin we use very frequently for certain types of infections. It has a whole other set of reasons why I don't like it, but that's more about monitoring and safety. When it comes to PO vancomycin, that's only really exclusively used for C. difficile treatment. So we don't really use it until we already know someone has a C. difficile. But I would say that's one of the conundrums, right? The treatments we have for C. difficile are actually going to adversely affect their microbiota and put them at greater risk for subsequent recurrences. So it is that delicate balance of decreasing that duration. And vancomycin does have broad gram-positive coverage in your gut, as well as some, anaerobic coverage, et cetera. And so you will have off-target effects on it. Fidaxomicin has slightly less. It's a little bit more narrow spectrum, which is one of the reasons why it's postulated a mechanism why it's slightly better for reducing recurrence risk. So, you'd think that would have played out clinically as being a little bit more effective, but as I shared, there's some more recent data that shows it's not all that much more helpful.
I guess my first thought is that question that you alluded to of when someone is test positive, has loose stool, had C. diff before, and what the heck is it? I was working with their local FMT group a little bit on trying to help sort that out because we see the situation that you alluded to. And we ended up interposing a fairly strong rule on whether or not they responded to oral vanco. It's even if people relapse, they actually should respond to oral vanco. If they have diarrhea, let them get better on vancomycin. But they don't like oral magnesium or something because we get these phone conflict, which we back to the question.
Yeah.
And so I was just wondering if you do that as well, if you weigh that heavily if you're wearing.
Yeah. So the question is for those online, with the diagnosis of C. difficile being so symptom-based, one of the factors that can be useful, and I didn't mention this, but I completely agree with you, is response to vancomycin with a previous episode. So when you're dealing with someone with recurrent disease, if they had a good response to vancomycin with their previous episode, they come forward with symptoms that could be C. difficile, but you're a bit on the fence as to whether or not it truly is. Sometimes just using a trial of vancomycin to try and see if they respond to it or not is helpful in establishing whether that was a recurrence. So I have done that, and sometimes that's all you can do. There are some patients, I would agree with you, I'd say probably 95% of patients actually do respond to vancomycin when they actually have C. difficile infection. I think in all the studies that we've heard, a slightly lower response rate to vancomycin. Probably those studies included people without C. difficile recurrence, right? So most will actually respond. For those who don't respond to it, what I found is sometimes they require a longer treatment and then they do respond. So there's this whole concept in my head, it's not scientific, of being past the point of no return, where there's been such ongoing inflammation of the gut without treatment, such that it takes longer for them to actually get control of their symptoms on the vancomycin. So sometimes I extend that treatment course for that reason. It is an important factor. Yeah. And yes, looking for other things like magnesium or other causes of diarrhea is important too.
I have a question.
Yes.
Dr. Cow says, thank you for your great talk. Can you comment on whether you have observed any particular ribotypes that are associated with recurrent C. diff?
Yeah, so the question is, are there any ribotypes that have been associated with recurrent C. difficile? Back in the NAP1 days, 027 days, absolutely. That was also documented to be associated with higher risk of recurrence. So I showed you the mortality and the severe disease data. I didn't show you that, but that was a problem. We see less NAP1, but interestingly, NAP1 is creeping up ever so slightly, at least I think in our community isolates of C. difficile. So we're keeping a keen eye on that to see if it changes what's happening clinically as well. There is what was previously NAP78, I think it's 078 ribotype strain of C. difficile that has derived from livestock and is a little more common in Europe. Surprisingly, we don't see a lot of it here in our surveillance. That also has been associated with higher risk of recurrence of C. difficile. And the others, it's a little hard because they're in much smaller frequencies.
Great. Wonderful. Thank you very much.